Yes, good to go.
Start?
Yeah, Sangeeta, go ahead.
Good evening, everyone. A warm welcome to all of you all to attend this webinar session today. Myself, I am Dr. Sangeeta. I basically practice in Oman for Royal Oman Police Hospital. I am a pediatric dental surgeon, and Dr. Nadia and Dr. Sheikha, both of them are also from Oman. They practice special care. Nadia practices special care and for special care dentistry, and Dr. Sheikha is also a pediatric dental surgeon. Both of them work for another hospital, which is a premium major tertiary medical hospital here in Oman. Dr. Sheikha, she'll be moderating the session for today. And we have Dr. Nadia, who's the very first special care dentist in Oman. Till recently, she was the only one. And as of now, we have only 2 special care dentists in Oman. So we have our founder members, Dr. Priya, Dr. Srinivas, Malineni, everybody is here. So I think we should go ahead. Dr. Sheikha, please preside over the session. Thank you.
Thank you so much, Dr. Sangeeta. Good evening, everybody. I would like to, first of all, thank the Federation of Special Care Dentistry for organizing today's event and for inviting my colleague, Dr. Nadia Al-Kindi, and myself to present and moderate this event. So I would like to, first of all, introduce my colleague, Dr. Nadia Al-Kindi, and talk a little bit about her, though she's very well known, and Dr. Sangeeta talked about her a little bit. So she graduated from the National University of Ireland, from University College Cork, and that's where she obtained her primary degree. Following that, she worked for the Ministry of Health, MOH, until she moved on again to Ireland to obtain her specialty in 2007 at the Trinity College, Dublin, and specifically trained at the Dublin Dental University Hospital. Currently, she works for the Ministry of Health, and she's one of the very first special care dentists in Oman, and she's highly involved in training other colleagues as well in terms of managing patients with disabilities and those who need special care in dentistry. She's also a co-founder member of an elected secretary of the Arab Society for Disability and Oral Health, and she is the elected vice president of Oman Pediatric Dentistry and Special Care Society. So Dr. Nadia, welcome, and the mic is yours.
Thank you, Dr. Sheikha, very much. And I'd like to thank the Federation of Special Care Dentistry as well for giving us this great opportunity to present and to meet everybody, although virtually, which can be a little bit daunting. Nevertheless, I think we're getting slowly used to the fact that we have to speak to the screen instead of having people, in front of us and speaking to real people. However, I'll try to imagine you all here and engaged, hopefully, and let's hope that this talk will also give a lot of questions, and would give a lot of time for discussion, hopefully, because I know it's a controversial topic, and I'm sure that many people who are attending today will have perhaps different views from the points that I'm going to raise in my talk. This is why I'll try to make sure that we give enough time for discussion at the end. And if the time does not allow us to continue with the discussion, I'll be more than happy to receive all your queries, all your comments, and all your questions, either via email or on my Instagram account, which I'll put on the last slide, inshallah, at the end of this talk. So, good evening. Let's make a move. We'll start with a scenario which can be very common on our daily basis as either special care dentists or pediatric dentists or even general dentists. We get patients come in with their parents demanding a tooth extraction that is a deciduous anterior tooth, mobile, and near age of exfoliation. many of these parents come demanding that, that the dentist or the clinician has to remove the tooth because they're worried that the permanent tooth is erupting behind that baby tooth and that there's going to be, problems in the future, and that the child will need, maybe an orthodontic treatment in the future. However, the child comes in very uncooperative, will barely allow the clinician to do an examination. So how will you pull out a tooth, give local anesthesia and pull out the tooth in this child? Okay, so this is a dilemma that we face very commonly, although dentally appears to be a very simple problem. However, when it's a child perhaps medically compromised or even medically fit, but with an underlying condition such as Down syndrome, and where cooperation is very limited, we are at a dilemma on what to do next. Okay. And if the parents are very demanding, very pushing, and suggest, we'll just hold the child down and you just pull the tooth out. Okay, how appropriate is that? Do we, follow parents' desires? Do we have our own opinions and that we need to, focus on and implement during our daily clinical work? Or what do we do exactly? Okay, or do we push for general anesthesia or sedation to pull out a wobbly tooth? Okay, so although the story or the scenario appears to be quite straightforward, however, the ethics behind our decision making can be a little bit more complicated than it seems. Okay, so we'll move on. What is restraint? In English, restraint is holding back from action, repressing a person, deprive somebody from liberty, or limit action. So that's the definition of the word restraint. Okay, from a medical point of view, restraining a patient could either be physically by using a device or by holding the patient, or chemically by using sedation and general anesthesia. So either ways, whether it is pharmacological or non-pharmacological, by using any of these methods, we are practically restraining a patient or limiting their ability to move. Okay, so physical restraint, specifically from a medical point of view, is a method that, as I said, by using a material or an equipment that will restrict the patient's freedom to move and to touch their body. Okay. There are many terms that can be used to describe physical restraint. Some countries use clinical holding, such as in the UK and in Ireland. Some institutes use the term physical intervention, maybe protective stabilization or immobilization. There are, many ways of describing the same thing, which is holding the patient down and limiting their movement during a medical procedure. Okay, so as we know, as pediatric dentists or special care dentists or even general practitioners or general dental surgeons or of any specialty, when we are faced with a patient with a challenging behavior, when we are faced with a person who does not allow for you to provide dental care to them, then there are many strategies, many behavioral strategies that we can choose from. Okay. Okay. Zoom is giving me a warning.
Yeah, it just says it's recording. You can go on.
Okay, because there's something on my screen that I can't remove. Anyways, so there are many factors that can influence our decision making. Okay, in order for us to try and control that unwanted, challenging behavior for our patients. And we've been taught this, in undergraduate level and in postgraduate levels about these behavior management techniques. However, how do we decide what is best for our children, of our patients, whether they are children or they're adults with the special healthcare needs? Okay, I can't move forward because there's this warning.
Maybe just press got it.
I can't, there's no cursor on my screens.
Maybe the technical team can help.
Your screen is moving, Dr. Nadia.
Okay, it's moving now, sorry. Okay, so the first factor that we need to consider when deciding on which behavior strategy we want to use for the patient is their disease status, okay? It is very important to note whether the presenting case is an urgent or is an urgent case, is requiring urgent intervention, urgent treatment, or whether it is something that is, you know, a more chronic problem. And also the other thing is to consider whether the care that we are providing, whether it is preventive care or is it a treatment. Considering things like the presence of pain, presence of infection, presence of pulp involvement in the child or in the patient that is coming to see us. The activeness of the dental disease in that patient. So all of these factors, the overall health of the patient, all of these factors need to be considered in order for us to decide what type of behavior strategy we want to use. Obviously, we can see that most of the dental treatment that we provide, whether we're pediatric dentists or special care dentists or general practitioners, are really limited to these procedures. These are the common procedures that we commonly provide for our patients. And we like to think that the behavior modalities really matches this pyramid. So the least invasive will require the minimum behavior strategy. Unfortunately, that's not really the case, because sometimes as simple as an examination may be, as simple as applying, you know, fluoride varnish to the patient, sometimes cooperation is so limited that it will not allow, the patient will not even allow for that. So simple behavior management techniques may fail in this situation. The next factor that we need to consider to determine the strategy we want to use to control an unwanted behavior is the developmental status of the patient. So how old is this patient? Is the patient, you know, a few months old or few years old, or is the patient an adult? Okay, because that may give us some clue of, you know, what type of behavior technique we can use for the patient. However, age is sometimes not very helpful in terms of this decision making, because as we know, in special care dentistry, we have patients who are adults, however, they're developmental delayed. So the chronological age does not really match their developmental status. Their physical development, again, is something else that we need to consider. So, you know, things like distraction or things like, you know, modeling or things like soft talking may be easier when the patient is corresponding to you and is physically easier to hold down gently if you're trying to do an examination, while in comparison to somebody who is physically quite large, then gently holding the patient may not be feasible. The other element in this type of, or in this category, is the level of their social abilities. So if the patient has, for instance, difficulty in socializing, such as in children who have autism, then it can be quite difficult to use some of the modalities that are commonly used in children. The ability to function independently is, again, another factor that we need to look at, and the intellectual ability and the linguistic abilities of these patients as well will determine, or will at least help us determine and choose and make a decision on what behavior strategy is suitable for this specific patient. Again, I'm stuck. I don't know why. And I still cannot remove the the Zoom warning that this is recorded. I'm sorry.
Praveen, can you please look into this?
Yeah, you just click on got it, that button you have to click.
Sorry.
You have to click on that got it button.
Yeah, but my cursor is not showing when I'm screen sharing.
We'll do one thing. I'll just stop sharing so that now I think you can see. Can you see, ma'am, now?
Yeah, it's moving. The warning box is still there from Zoom. It's over my slides, but it's okay. As long as my slides are moving,
Now,
I'm okay.
stop sharing. You need to reach.
Am I sharing now?
Not yet. You have to reshare.
Okay. So I go back to Zoom. I'm sorry about this. Okay.
Yeah, no, it's okay.
So
It's
it's
okay.
important. Yeah, it's important to recognize why our patients are fearful, why our patients are lacking the ability to cooperate, okay? Once we know the causes for the lack of cooperation, it can be easy, or at least not easy, but it can be helpful to try and find out ways around helping the patient become more comfortable coming to see us in the clinic. The next factor is about parents and the parental characteristics. This is a very important part on our decision-making, about our decision-making on which behavior method we want to use, okay? I'm sure that most of you have come across parents who think that baby teeth are just baby teeth and that it's okay to leave them untreated if they have dental diseases because eventually they'll fall off. Or sometimes they come insisting on extracting these teeth because again they're just baby teeth and that the child will have new teeth growing in the future. So I'm sure this is true across all cultures, or at least across most cultures, okay? So when parents come in with this type of belief, it can be very difficult to convince them otherwise in terms of, we need to use certain type of behavior management so that we can treat the teeth rather than leaving the teeth to rotten away. The cultural opinion really matters, again, when it comes to the behavior methods that we use in the clinic. Being in Ireland for a while, coming back to Oman, I've personally noticed this difference. So there are differences in the preferences depending on where you're working. The parental acceptance and their preferences really vary between countries from east to west. And there are a number of studies in the literature that confirms these variabilities. There's one study that I came across where it looked at parental acceptance for physical restraint in children with learning disabilities. And surprisingly, when compared to children who had no disabilities, parents with children with learning disabilities actually preferred physical restraint over general anesthesia and other type of other methods of behavior control or behavior management. So what influences parents' acceptance? The literature tells us that it's the economical status of the parents, the educational level of the parents, the age of the child or the age of the parents, previous experiences when it comes to restraint, whether it's physical or chemical restraint, and also the personality of the parents can affect their acceptance to a specific behavior strategy that a clinician may suggest for their children. As I said earlier, that there are differences in cultures and differences between countries on parental acceptance. I'll just give one example of a comparison between a study done in Brazil and another study done in Kuwait. In Brazil, in this study in Brazil, the parental acceptance for active restraint increased with age of the child and age of the parent. So the older the child and the older the parent, the more acceptant they were to active restraint. However, this also was true with the parents having low economic income and who were at a lower educational level. And also the presence of parents really mattered on whether they chose active restraint over other types of behavior modalities. In the same study, parents accepting passive restraint, on the other hand, increased with younger patients. So for patients who are over 10 months up to 4 years of age, they preferred passive restraint in this age group. And actually previous experiences in restraint for these children increased the parents' acceptance on using passive restraint for them. In comparison now to the study done in Kuwait, parents there had the acceptability of parents to the different behavior modalities in general was not influenced by the age, whether age of the parent or the child, the gender, their nationality or educational background, or even their occupation. And they all agreed that they preferred to be present in the operating room during a dental procedure done with a behavior technique. In all the papers that I came across with, and also the new guidelines and all the policies, conclude that behavior management strategies that were used comfortably in the past, such as physical restraint and hand over mouth and voice control, are actually losing societal acceptance. And parents are more and more inclined to choose other ways of the behavior management, which is, the tell, show, do, or the modeling, or the distraction, the other least invasive ways of controlling or managing a challenging behavior. These studies also concluded, and they've all agreed, that parental acceptance was influenced by information given. Okay, so if a parent is given enough information about how the behavior strategy is going to look like, maybe shown a video or a photograph before starting treatment, that actually allowed for acceptance for the parents, whatever the behavior modifying technique used, and that successful treatment really dependent on participation of parents. Okay, so their presence in the surgery inside your clinic has a very positive effect on the success of the treatment, because in many times they will be involved in soothing the child, in gently holding the child when required, and so on. Although I know many clinicians, maybe in other parts of the world, follow the rule of not having parents inside surgery during treatment. However, many of the studies agree that the presence of the parents inside surgery has a more positive effect on the success of treatment. Something else that we need to consider is understanding and knowing the type of parents that we're facing inside or during treatment, because this really affects our decision making, whether we like it or not. We are being pushed sometimes on making decisions that are perhaps not really aligned with our beliefs or with what we want to choose. So once we understand and know the parents' personalities, we can know how to manage and deal when there's pressure on us onto choosing and onto deciding the behavior strategy that is suitable for the patient. Patients or parents who have appropriate attitudes and who are maybe super parents who want the best for their kids are usually much easier to handle because they transfer authority to us and they tell us, you know the best, so you decide, and we are here to support the child and, and be, a helpful factor rather than, a negative factor. However, when we have parents who are overprotective, maybe demanding, sometimes hostile, it can be more challenging because these patients need to be managed very carefully, and communication needs to be optimum, whether you need to be more authoritative on your discussion or more, soothing and more, gentle on giving the information to these parents. So it is important that we understand, as well as understand our patients. It's very important when we're dealing with patients who attend with parents or with family members that that we understand the personalities of the parents. The next factor on that may influence our decision making in what type of behavior management technique we want to choose is really us. Okay, our personalities, our capabilities. Sometimes we don't realize it, but we are different. I may be different from Dr. Sheikha. Dr. Sheikha is different from our other colleagues. Some of us have more authoritative style, so we want to push for what we believe is right. Other clinicians are more empathetic in their approach. And we have also colleagues and other doctors who are more personal in their approach when they are managing challenging situations. So really, our personalities can sometimes affect our choices of what type of behavior strategies we want to use on our patients. Other factors as well that are important in developing these behavior strategies are our experiences. Obviously, the more experienced a person is in managing challenging patients, the more certain types of behavior strategies that will work better. Another factor is what specialty we are working at. So perhaps a surgeon may prefer general anesthesia over simple tell, show, do, because this is them. They just want to go in and do their job. But when you are a pediatric dentist or when you're a special care dentist, we are more inclined to take it step by step, tell, show, do, and modeling and so forth. Okay, so it really, really matters, and the literature shows that it, our specialties will determine what type of behavior modality we are going to choose. The practice location is an important factor as well. Perhaps I'm going to speak further in another slide. It has been shown in the literature that in specific areas, clinicians are more inclined to use one modality over the other. Our educational backgrounds, maybe our age and our gender can influence and determine what behavior management technique we want to choose for our patients. Access to sedation and general anesthesia is a tricky one, okay? And it's although it is not listed as a factor, but it is a factor that can influence what we decide. We know that commonly many medical interventions are done under general anesthesia or even under sedation. However, when it comes to dentistry, people are more reluctant to go for sedation or to go for general anesthesia. Okay, in the studies that looked at parental preferences, the majority thought that they had, that general anesthesia was their least chosen type of restraint that they want for their children. However, the studies also show that parents who had previous experience with sedation and previous experience with general anesthesia were okay with choosing these two modalities for managing their dental treatment. However, when access to sedation and when access to general anesthesia is limited, like in many countries, then sometimes one needs to resort to other ways of behavior management for the patients. Excuse me. Okay, the other thing that we need to consider is the healthcare system in in the country or in the area that you're working in, because, excuse me, if we take the example of Oman, for instance, when I was introduced as the first special care dentist in the country, this really translates into that there are few of us already in the country. So any patient who requires specialist care, who has special healthcare needs, will have to travel to me in order to receive a dental care. Okay. In many instances, patients travel a very, very long distance. They arrive to the clinic demanding that treatment needs to be done on the spot. They don't realize that coming to see a specialist usually for the first time is actually a consultation visit, and that treatment will be done further in the way. However, culturally, they sometimes come demanding for treatment on the spot, or perhaps the patient is in severe pain and that they needed some treatment done on the same day of the visit. We have a very long waiting list when it comes to general anesthesia, and a very, very, very long waiting list for sedation. Most of the time, sedation is used only as an emergency situation, and we don't have like a routine list for sedation. So really, the healthcare system where you're working at sometimes will determine and will influence very much on what type of behavior strategy that you can resort to when you are trying to manage a challenging situation of a patient who will not comply to a dental treatment. Fortunately, we have many guidelines and many policies in the literature that we can resort to, so that when we need to use other modalities for providing care to those who are challenging, and that and that access to general anesthesia and sedation is limited, we can use these guidelines to help us determine what is the right way to do things. And the two most common policies or guidelines used, at least in our part of the world, is either the American or the British guidelines. The major difference between the American and the British way of using restraint is that in the States, the American Academy of Pediatric Dentistry recommend the passive restraint, so using devices that holds the child or the patient and limits their movement. While in the UK and in Ireland, clinical holding is more recommended and is advocated, which is considered an active restraint for the patients. The Arabian Academy of Pediatric Dentistry has also recently published a position paper that gave guidelines on the use of restraint for patients who require restraint. And they have a very nice flow chart for decision-making process. So if we go into detail and look at this chart, starting from the top, if your patient has any medical or psychological contraindication to use, they call protective stabilization or physical restraint, as my title entitles, then if there is a contraindication, then using restraint or protective stabilization is not appropriate. If there are no contraindications, then you need to look at the urgency of the procedure and the length of the procedure. If it is not urgent and the procedure is considered to be a long procedure, then again, using protective stabilization is not recommended. The next step is then to make sure that there is informed consent obtained from the parent, and that there's been a discussion with parents, all the information has been given, all the risks and benefits, advantages and disadvantages, and so on. And also if there were any other alternatives considered for the patient before proceeding with the treatment. We are lucky that we are living in an era where new ways of treating dental diseases has emerged. The use of minimal invasive or atraumatic restorative treatment has been proven now that they are very successful, at least as an interim before the child or the patient requires, the final dental restoration or the final dental treatment or the more permanent dental treatment. So, the presence of this silver diamond fluoride, for instance, to arrest caries has really saved us a lot of time and also helped us manage those challenging situations where in the past we had to drill and excavate caries. And I think that we are lucky that we are living this era, that that's been introduced to our daily clinical practice. And then finally, the most important point in this flowchart is the last blue box at the end, if the person is trained or not on the use of protective stabilization. Okay, because you will know either from your daily practice or from your training that being trained on stabilizing patients and clinically holding patients is very important for pediatric dentists and special care dentists. So when do we commonly use restraint? Because as I said, sometimes it is not possible to use the other modalities. You don't have urgent access to general anesthesia or sedation. Other modalities will not work for people with learning disabilities, who are in the autism spectrum, who are on the autism spectrum, patients with involuntary movements or who are unable to control their movement, patients who are severely anxious and who are perhaps likely to respond aggressively if not being held, patients who lack capacity to understand. So trying to do a tell, show, do modeling technique with these patients will not work for them. So sometimes we have to resort to physical restraint or clinical holding for our patients in order to be able to provide dental services or dental care rather to the patients. So we carry the duty of care to our patients, okay? So we use restrictive physical intervention so that we are able to deliver effective assessment and effective care to our patients, clinical care in terms of treating them and in terms of reviewing and following up their progress after we've completed the treatment. So it is very important. It is our responsibility that any action or any decision we make it based on the necessity of that decision, and that we work on the aspect of best interest for the patient and not otherwise. So not a personal decision because we enjoy it or we like doing it or that it is easier and more cost effective and faster. Okay, so any behavior strategy that we choose needs to be based on necessity and that it is for the best interest of the patient. And physical intervention or physical restraint or protective stabilization, clinical holding, whatever you like to name it, it should be chosen as the best option for the patient. Okay. Any intervention that we choose, specifically if it's physical restraint, it should not cause pain to our patients, okay? Patients should not be completely immobilized. They should be able to have some form of movement that will not interrupt their care and that will not cause harm to themselves or to the people surrounding them. As I said earlier, the treatment that we are providing using restraint or using clinical holding should be urgent and necessary. And that treatment and the approach that we choose is merited. I want you to remember the 6 A's for safeguarding patients during a clinical holding. Attitude, avoidance, so as we said, only if necessary. excuse me, assessment. So assessing the patient and having any treatment plan patient-centered. So assess the patient well, their medical background, their cultural background, what is appropriate, and so on. Approval is next, because as we said, consenting for any restraint is very important. Information given to parents is very important, and that needs to be well documented in the clinical notes. Next is authorization. So deciding beforehand who is going to be involved, who is going to hold what, and how is the holding going to be. Okay, so everything needs to be planned beforehand. And then finally, appraisal, because it's very important that after every session, when physical holding is involved, that a review of the whole session is required to see how well things went, how bad they went. Okay, what went wrong, and why did it go wrong, or how did it go well, and why did it go well? So all of these things needs to be critically appraised and reviewed by everybody involved in the care of that patient. So best practice when using physical restraint or clinical holding is that ideally it needs to be part of a wider strategy. Okay, so used together or in conjunction with sedation or distraction. Again, I keep repeating this, use as the last option. Try to find other ways of managing a challenging situation. Everybody needs to be trained on clinical holding. We need to be aware of the risks and monitor the patient while the holding is happening during treatment. Need to be aware of any medical emergency that can occur during holding. It should not be used to force control. Should not be used as a punishment because they do not comply, then they have to be held down. It should be for minimum duration, as I said, with a minimum restriction, so allowing some form of movement. And it should be planned and patient-centered or person-centered. So not all patients with challenging behaviors, not all patients with intellectual disabilities will require holding. So every patient is different. Every patient needs to be assessed individually. So what are the risks? If somebody decides on clinical holding or physically restraining a patient during dental treatment? Well, the risks are using this technique would be soft tissue injury, maybe psychological distress, maybe some bony injury, respiratory restrictions, cardiovascular restrictions. These are some of the risks that we need to be aware of, and we need to inform the parents about them. So we need to watch out while we're holding the patient down. Things like, verbal complaint. If the child or the patient starts complaining that it hurts somewhere in their body, we need to watch out for these and respond to the complaint. Any physical changes in their breathing, in the color, any loss of consciousness, as I said, medical emergencies such as seizures, any presence of a swelling in the areas where the person is being held, any psychological changes. So a patient suddenly starts crying, or a patient suddenly starts laughing, or whatever changes that you may see in a patient, then you need to be aware that there's something happening that you need to opt out and you need to stop and ask yourself, why are we holding this person this way? What are the risks now? What can be done to reduce the risks, and can we stop? And if we stop, what will happen if we stopped now? Okay, will there be an aggressive maybe response? Will there be harm caused to the patient if we stop, and so forth? So there needs to be a sequence, and every case needs to be studied well and assessed well and planned for their care very well before and during and after a clinical holding or a physical restraint. We never use physical restraint or clinical holding if the patient obviously is compliant or is cooperating. Okay, Patients who have some medical or physical conditions that cannot be stabilized safely, that's a contraindication. Patients with history of psychological or physical trauma in the past due to stabilization. Patients who have no urgent treatment really, or their treatment can be delayed, and use other ways of managing their behavior, and also lack of training of your team. Okay, these are the contraindications for using clinical holding or physical restraint. We need to recognize our own strengths and our own skills. A practitioner of any level of experience must not only consider the dental disease itself, but also the interaction, communicating with your patient, communicating with the parents and the guardians and of your patient. This, interaction between you, your patient, and their family is very important in the decision making about the treatment that you want to provide, about the advantages and disadvantages of the technique that you've decided to choose for your patient, in order to complete a successful, effective treatment for your patient. Okay, so everybody needs to be involved. It's not only the dentist decision, but it's an interaction between everybody involved. So to answer the question, are we threatening or are we serving our patients? Okay, we are serving our patients if we adhere to the proper steps and and if we adhere to the guidelines that are available. Education and formal training is very important in all those who are involved in clinical holding. Parents' involvement, parents' presence, as assigned informed consent with all the advantages and disadvantages of clinical holding is very important in order to ensure that the service we're providing is proper and is suitable. All other approaches and all of the other strategies have been explored before we decide on clinical holding for our patient. As I said earlier, we are lucky that we have policies and protocols and guidelines to guide us. So be familiar with these and follow them. And also act on the basis of do no harm, but rather act in the best interest of our patients. Okay, I came across this very cute video and I thought it's very suitable. So we'll end with this. Wow, that was amazing, I think. And if we all follow this doctor's way of managing patients, I think we'll do magic with our patients. So I think time is always the secret of success. If we give time to our patients and allow time for them to feel comfortable being with us, really we will come across, we can skip a lot of difficulties and challenges if we give time to our patients. Okay, so that's it. Thank you very much. And I hope we have a number of questions for discussion and for answering. Dr. Sheikha?
Yeah. Thank you very much, Dr. Nadia. That was a very informative presentation. And I'm very happy that it's recorded so everybody can go back to it, and those who were not able to join can go back to it later on. So I'm just going to check now if there are any questions, and I'm sure they are, though you have covered a lot of things during your presentation. It was very, very informative. And I'm sure everybody agrees with that. So thank you very much, Dr. Nadia. Let me now see if there are any questions. Okay, so I would like to remind everybody that we are happy to receive questions now. If you can just put them in the chat area. Okay. Okay, I'm still waiting for your questions, everybody.
I'm surprised. I was expecting a lot of questions because I think this is
There's
a
a
very
question
controversial topic. And I was waiting for people
Okay.
to.
So there's a question. There's a question here. Well,
Okay.
few are starting to come here. One question says, how many in a team would you recommend for physical restraints? How many members in a team, maybe, would you recommend?
Okay. If you have well-trained dental auxiliaries, you will need a minimum of 2. That's a minimum number.
Maybe beside the carer or the parent. Yeah.
Well, yes, besides the parents, yeah. Some parents want to be involved in the holding process, and some parents refuse to be involved, and we totally respect that. I know some specialists or consultants in pediatric dentistry who refuse to hold patients, either themselves or with their dental auxiliaries, and only accept holding done by parents. So they give the parents the authority to hold the child, and allow, you know, themselves and their auxiliaries just to focus on the dental work.
Yeah.
Yes. But if you are talking about the dental team, then a minimum of 2 dental auxiliaries is the ideal to have a proper clinical holding.
Mm-hmm. There's another question here that says, how can we convince neglectful parents to go ahead with emergency treatment?
Whoa, that's a hard one. Neglectful parents are challenging parents, but we need to understand the background of their neglect. Is it really neglect, or is it what we see that we consider neglect? Neglect to me is somebody who is, you know, who does not look after their child's oral health. Okay. When you have or does not bring the child for follow-ups as requested or as planned, they don't attend for prevention and only come when there's pain. So maybe these are parents who we may think are neglectful. However, in my practice, at least, I'm very considerate about the fact that many of these patients, or rather many of these families, have so many other issues going on with their children, because they're special needs patients. They will have issues, right? They will have underlying medical problems. They will have, you know, multiple hospital appointments to attend to. They will have maybe social issues, economic issues. So I normally don't tell them directly that there is neglect or there is a problem in how they're looking after their child's oral health. However, I always try to offer help in terms of their dental problems or their dental needs. So offer them, maybe ideas on how to clean the teeth. Try to accommodate the appointment so that maybe they're on the same day as their appointment at the other hospital. Try to listen to them. I spend a lot of my time in the clinic listening to parents complaining about their own personal problems, their problems with other doctors or other hospitals rather, and health problems of their children. And I don't focus much on the dental problem, at least initially. but try to absorb the family's problems and then suggest ways to help them, get their things sorted, and then eventually, give them or at least offer them, if they wanted help in terms of technique on brushing the teeth, maybe ideas of what type of toothbrushes that are available in the market for them to use, or the toothpaste. When they're worried about bleeding gums, so you try to give them information in such a way that you're not blaming them for causing the bleeding, but rather giving them solutions, and try to overlook the neglect part of from their side. So I don't know whether that answers the question. So how do I convince a neglecting parent on extracting the teeth? Was that the question? I forgot the question.
It says to get treatment done, to get emergency
treatment. Well, to be honest, once they're at your clinic, then they want the treatment, right? They rarely come to you if they don't want treatment.
And to add to you, Dr. Nadia, some parents they travel to see many dentists. I noticed there's this fear from GDPs sometimes to manage, for example, patients with disabilities or with medical issues. So you would see some parents have been visiting several clinics in order to get the treatment done, but they don't get the treatment done because there's this fear from the GDP or whoever have seen them before that, no, you have to be seen by a specialist, even though the treatment can be simple. So we shouldn't just blame it on the parents. We should also blame ourselves sometimes. We should, yeah.
Yes, they were neglecting the dental problem, but as they've come to see me, so that just translates that they care about their dental issues, because they've traveled all this distance to come and see you. So it's easy to convince them for the treatment.
Okay, there is another question here that says, just wondering why the access to sedation in GA in Oman is difficult.
Okay, because dental services are limited to specific centers, especially for those who have disabilities or who are medically compromised. So the number of hospitals are limited, or the number of dentists are limited, or specialists rather, who provide services to these patients are limited. So it's really a matter of resources. We're limited with resources, and the number of patients is quite high. So this together with the lack of access to GA or to get appointments for GA, in combination will increase the waiting list, so that results in difficulty in accessing. When I say difficulty in accessing, it is available, but however, the waiting list is very long. With regards to sedation, dental sedation is not accessible as routine. It's only accessible for emergency situations. But however, we have been working on at least on IV sedation to have it as part of a minor surgery in our hospital. But this is a long process. So there's a lot of logistics and a lot of politics happening. So hopefully next time we meet, or next time I give a talk, we'll talk about sedation in Oman, inshallah.
Okay, the next question is there any country which has guidelines against physical restraint?
Against it?
Yeah, totally against it.
Yeah, I haven't come across. If you know any guidelines that totally, what's the word? Contraindicate, not contraindicate, but totally is against physical restraint or clinical holding, then I'd be very interested to know. All the guidelines that I have come across are there to help people who have to provide dental care by using physical restraint. So I have not come across any law or any guidelines that does not allow the use of restraint. But if there is, I'd like to know it. I'd like to know.
Okay.
I don't know.
So-
Especially, do you have any guidelines that do not allow the use of restraint?
Not really. So the next question is, what is the scope of hypnodontics in managing these kids? Maybe the use of hypnosis?
Hypnosis, maybe, yeah. Hypnosis is quite effective in many patients, especially in the children, in children who are, intellectually able. However, I'm not trained to use hypnosis. I haven't come across anybody who does hypnosis in children with disabilities. So I can't really give more information about the effectiveness of hypnosis in this group of patients. But I am aware of the use of hypnosis and the effectiveness of the use of hypnosis in specific type of patients. I don't think it works for everybody.
Okay, next is, can we combine conscious sedation and physical restraints in younger patients?
Younger as in, I'm not sure what's the age group we're talking about, but yes, ideally, clinical holding should be in conjunction with a type of sedation. That's the ideal situation, yeah. Because sedation or any type of sedation does not completely knock out the patient, right? It's unlike general anesthesia. The patient is still, has still consciousness and is still able to move. So some form of holding will be required for some patients who are, very comprehension and are not able to cooperate for dental treatment.
And we have two questions from Dr. Salahuddin Al-Azd. He says, is there any ethical intervention to perform physical restraint? And the second question is, what are the advantages and special situation of physical restraint in comparable to sedation?
Okay, the first question, are there any ethical
intervention to perform physical restraint?
I'm not sure I understand the question, but maybe the question, he means any regulations?
Maybe, yeah.
It depends on where the person works. There are countries with very strict regulations regarding clinical holding and strict regulation regarding adherence to the policies that are put in these places in terms of using clinical holding. So I'm not too sure whether that answers your question. The second question is whether holding has any advantages over sedation.
Yes.
Personally, no. I think sedation is far more better than just using clinical holding alone. It is less traumatic to the patient when the patient has sedation. And as I said, in many cases, some form of holding may be required together with sedation because, as you know, if you're practicing dental sedation, it is very minimum. We don't put our patients in a very deep state of sedation. So there will be some form of holding required. But the beauty of IV sedation, at least, is that the patient does not remember what occurs during their treatment. So any physical holding that would be needed, the patient will not recall that once this effect of sedation wears off. So no, I don't think holding is more advantage than sedation, but it's more accessible. It is a minimum cost, obviously, because sedation will cost money for the health institution. What other advantages for holding? It can be done on the spot. It requires, it requires planning and requires discussion of the advantages and disadvantages, but it does not require much equipment, especially if the holding is done, using active restraint, using somebody else, clinical holding rather than using a device. So maybe we can consider those as advantages. I'm not presenting this as an advocate for clinical holding. It is something that I try to avoid as much as I can. But I also know that clinical holding is an option, and that sometimes we are, we have to use it as a form of behavior strategy to help us and to help our patient get their dental care needed, especially if the dental care needed is urgent.
Okay, I think we should take one more question that I find very interesting. It says,
Okay.
due to limited GA sessions and ICU beds due to COVID-19 pandemic, do you see the trend of physical restraint? Do you see it going up, using more physical?
Yes, unfortunately, this is one of the one of the consequences of not having access to general anesthesia. We're seeing more and more patients being referred to as emergency cases, with abscesses, because they did not have access to the general dentist initially when the problem was just in its initial stage. So they end up being referred as an emergency with big swelling of the face that requires drainage through a socket by extracting a tooth. However, we are lucky, to be honest, in another hospital in the Ministry of Health, is that patients in the special care clinic have the privilege of accessing GA almost all the time. We had a very limited time where we needed to stop general anesthesia in our hospital for dental services, specifically for patients with special healthcare needs. So I think we were one of the lucky ones where the service was not very much affected by COVID-19. So yes, there's more and more patients requiring holding now than in the past due to limited access to general anesthesia. However, I must say we have been lucky that our services more or less continued. Perhaps the numbers were reduced, but the access was as it was in the past. And actually, for some time, we had increased access. We had more number of days that we could attend the general anesthesia or the operating theater than our colleagues in other specialties. Our patients were given privilege to access GA.
I think Dr. Nadia has answered most of the questions and has kindly provided her contact details. If you have any other questions, you can contact her, as she said. So I think we should conclude it then.
Yes.
So
yes,
thank you very much, Dr. Nadia and the Federation, for organizing this event. It was very informative again. I'm glad to be part of it. And I'm sure everybody who attended will agree that they have learned so much today.
Thank you, Dr. Sheikha, and thank you for the Federation for organizing this event. And I look forward to many more in the future, inshallah.
Sangeeta, you have to unmute.
Thank you, Dr. Sheikha. Thank you, Dr. Nadia. It was wonderful having you all with us. And we would love you all to join us on the Federation. We'd love you all to be there. And I think I'll ask Dr. Srinivas Namineni to present the certificates to Dr. Nadia and Dr. Sheikha. I would like to inform the participants who all have registered. You will be able to download your certificate once you have filled in the feedback form, which is available on the link. So once you've done that, you'll be able to download your certificates. Only the registered candidates will be getting their certificates. Sir, please present the certificates to Dr. Nadia and Dr. Sheikha, please.
Thank you very much, Dr. Nadia. It was a wonderful presentation. Use of physical restraints is something very sensitive and personal to both the parent and the child and the clinician also. When empathetically used, it's a win-win situation for everyone. So empathetically used. I think I underline that word, empathetically used. So that everybody would get benefit out of it rather than making it look like a, using of a force unnecessarily. Thank you very much. And it was wonderful listening to you. Thank you very much, Dr. Sangeeta, Dr. Shiaka, and
Thank you.
wonderful for rest of the people who joined us for this webinar.
Okay.
Priya,
Good night.
Dr. Priya would update about the membership information of Federation of Special Care Dentistry. And Priya?
At the outset, thank you, Dr. Nadia and Dr. Shaika for coming up and teaming up with us for this wonderful and much needed presentation. Physical restraint is as I always address it as, it's a double-edged sword. And Sir rightly pointed it out as an empathetically used terminology. Well used within the guidelines, it can be a boon to all of us. Else, it could be termed as a form of an abuse given to the child, taking an advantage of the size of his body, or being in a situation of not being able to defend themselves. So thank you very much for this insight and your take on the much controversial topic. And I would also like to invite you to join us as members, as esteemed members of a Federation of Special Care Dentistry. The Federation is open to anyone who has keen interest in the area of special care dentistry, and we look forward to work with everyone and from all from any part of the world. The idea is to create awareness and join hands together so that we're able to deliver a better service for this section of people or patients. Thank you. Over to you, Dr. Sangeeta.
Yeah, thank you all of you all who have joined us today. And Dr. Nadia, it was a wonderful, informative session, and I am really grateful for having you on this session. Yeah, thank you so much.
We look forward to hear more from you.
Oh, yeah, from this part of the world. Yeah.
Yes.
Thank you. Thank you. I think we should conclude the session, right?
Yeah.
Thank you. Bye.
Bye-bye.
Bye. Thank you, everyone.
Okay. Bye-bye.
Bye-bye.